Welcome everybody to this month's webinar from the American Journal of Bioethics. I'm David Magnus, the editor-in-chief of the journal. Today we'll be discussing the ethics of vaccine allocation. Joining us for today's panel are Grace Lee, MD, Professor of Pediatrics at Stanford University School of Medicine, and Associate Chief Medical Officer for Practice Innovation at Stanford Children's Health. In her current role, Dr. Lee primarily serves as a clinical and administrative leader for the health system, focused on bridging quality, research, and implementation for the organization. Dr. Lee is currently a member of the U.S. Advisory Committee on Immunization Practices, ACIP, a member of the COVID-19 Vaccines Workgroup, and co-chair of the COVID-19 Vaccine Safety Technical Subgroup for the U.S. Advisory Committee for CDC, ACIP. We're also joined by Kathy Kinlaw, a Master of Divinity, who's a health system ethics consultant. She's also assistant professor of pediatrics and associate director of the Emory University Center for Ethics, where she directs the program in health science and ethics. She also serves as lead ethicist at Emory Healthcare and director of the Healthcare Ethics Consortium. Her research and writing addresses clinical and public health ethics issues, including critical care resource allocation and vaccine decision-making during the COVID-19 pandemic. She currently serves as a member of the ACIP COVID-19 Vaccine Workgroup as well. Govind Persad, JD, PhD, is an assistant professor at the University of Denver Sturm College of Law and a Greenwall Foundation faculty scholar in bioethics. He has published work on COVID-19 topics in venues including JAMA, the New England Journal of Medicine, Science, the Yale Law Journal Forum, and the American Journal of Bioethics. He has also co-authored op-eds in the New York Times, Denver Post, and Washington Post, and collaborated in the development of the University of Pittsburgh model policy for allocation of scarce COVID-19 treatments. And Govind's very well known for his work on allocation issues and a lot of his collaborations with Zeke and with Monica. Monica Peak, PD MPH, is an associate professor at the University of Chicago, where she serves as the associate director of the Chicago Center for Diabetes Translation Research, the executive medical director of Community Health Innovation, and the director of research at the McLean Center for Clinical Medical Ethics. Her research pursues health equity and social justice with a focus on promoting equitable doctor-patient relationships among racial minorities, integrating the medical and social needs of patients, and addressing healthcare discrimination and structural racism that impact health outcomes. Okay, so we are obviously in the midst of a massive effort to vaccinate people so that some levels of herd immunity from COVID-19 can be achieved. A number of competing frameworks have been developed, including a framework for the National Academy of Medicine, the ACIP framework that's been developed that Kathy and Grace have both contributed to, the approach to allocations that Govind and Monica and Zeke Emanuel have developed, and the approach that was developed out of Hopkins. And there are many others, WHO and many other approaches. We've also seen differences in priorities across states and logistical challenges that create further ethical tensions. Finally, we are witnessing a great deal of potential vaccine hesitancy from quite varied groups, but including high rates of mistrust among racial and ethnic communities that have been among the hardest hit by the pandemic. So with all of that in mind, I'm going to ask several questions, and then we'll turn it over to questions from the audience. And I just want to encourage people in the audience to use Q&A, the Q&A function, to ask your questions, and then you can also upvote questions. So please put in your questions, and then after a few questions that I'll be asking of the panelists, we'll turn it over to questions from the audience. So first, can you each briefly describe what you see as the key ethical principles that should govern vaccine allocation? And are there groups that you think states are ranking too low based on these principles, such as teachers, people with high-risk conditions, and everyone over 65? And I'm going to start this question with Govind.
Sure. Thanks so much, David. So yeah, in terms of the key ethical principles, I think I'll stick with the ones that Dr. Peak and I describe in the JAMA article, which still seem like the right ones to me. Maybe the first two would be, there are three. I think the first two and the most salient are harm prevention, so preventing harm, which we might think of, people often think of it just as preventing deaths, but it's also preventing outcomes like hospitalization and long-term medical complications, loss of caregiving, or other sorts of help that people might get if somebody gets COVID-19. And then the second principle that we talk about, we call priority to the disadvantaged groups. You could think of it as a sort of health equity or disparity reduction principle, where special attention should be paid to trying to mitigate the impact of COVID-19 on groups that have been systematically disadvantaged through sources like geographic vulnerability and disadvantage, structural racism, these types of issues. The last principle we talk about is an idea of equal treatment that we think of as just only considering relevant differences. So if groups differ in how much harm you can prevent or in their disadvantage, that's a legitimate reason to treat them differently, but not otherwise. In terms of specific populations that at least I think we've been, a lot of states have overlooked or placed lower priority on, I've been struck by the fact that despite ACIP talking about essential worker priority, many states have thrown that out entirely or have limited it very, very dramatically, really sort of ignoring both issues about transmission and issues about place-based and occupational vulnerability. I think you've also seen that to some extent for states throwing out or limiting the use of high-risk medical conditions. I think at the very least, it would make sense to incorporate these as overlapping risks. For instance, occupationally vulnerable or exposed people who are also older or also have high-risk medical conditions. I've been struck and disappointed to see states throw out those categories.
Thanks. Kathy, same questions?
Yes, thank you. So not unexpectedly, I'm going to be very supportive of the 4 principles that the ACIP Vaccine Workgroup and ACIP have been working with, which overlap a lot of what Govind just communicated as well. So those principles are maximizing benefits and minimizing harm, mitigating inequities, particularly, of course, healthcare inequities, promoting justice, and then undergirding all of that, really a commitment to promoting transparency along the way. I think these statements in general still serve us very well and have been reflected in the ACIP phases. Do we have it exactly right? You know, maybe not. I think there's, the reality is we've been actively building and making changes along the way as we see the real-time effects of the virus and learn so much along the way. But I will have to say that, you know, I still think that a lot of the work that was done to create the initial phases for ACIP, and again, I'll have to say other national groups like the national academies, you know, have done similar work, but using decision analysis and mathematical modeling have been very important. And of course, basing everything on scientific evidence that's been available along the way. And so the idea that, you know, we needed to have tiers, we needed to have some groups that would be higher priority in terms of vaccine dose receiving while we have limited amount of vaccine. And so, you know, I think the phase 1, 2 categories have been in general well received. And I think we're all hoping to be able to move forward with the older individuals over 75. And a number of states have already done that and have done, in fact, 65 and older. But we did base the distinction for 75 and older over particular information available to us at the time, which I can talk about later if that's of interest. But also, as Govind said, the move to essential workers, who of course are at increased risk of exposure to the virus due to their responsibilities and inability to work remotely or to physically distance on site. I know there's a lot of advocacy and important advocacy for particular groups. For example, for teachers, getting our children, you know, back to an optimal learning environment. Individuals living in at-risk congregate settings like prisons. And I think these are really important populations to take into account as we move forward. But I think I'm supportive of moving forward the phases that we have at this point.
Thank you. Monica?
Yes, thank you so much for having me, David, and I'm just really honored to be in this group today. I agree with all of the ethical principles, and I think that it's important that we do have an ethical framework because the issue is so complex. I think the one that is the most challenging for us as a country to wrap our heads around is the one of equity. And that's the one that I think we need to lean in most because it's the one that's the most difficult for us to implement. And it's the one that is showing its head as far as disparities. And so if we want to really try and mitigate the public health impact of coronavirus in our country, we really have to use a public health approach in thinking about which are the groups that are most affected and are disparately affected. And that is racial and ethnic minorities, other socially marginalized groups. But because we historically have had a really hard time wrestling around issues of race and social marginalization, we have had a really hard time trying to disproportionately allocate resources to those groups. And so that is the ethical principle that I think we really need to elevate and work on, because that's the one that we have done the least due diligence in sort of pushing through. Our system of allocation really, as is, assumes that there's a level playing field, but there's not. And so unless we purposely wrench in mechanisms for equity, what we're going to see are disparities in outcomes. And so we're seeing those now unfold, not in vaccine utilization. Some of those are from vaccine hesitancy, but when you have marked high rates of vaccine demand, then we're washed out. The issues around vaccine hesitancy are washed out. And so what we're seeing around vaccine disparities already really is a reflection of disparities in implementation. And so we really have to think about what we're doing wrong in adhering to the principle of equity and how we can readjust that. And so that's the one that I would highlight. And the groups that I would highlight then subsequently are those that are impacted by not focusing on that equitable principle.
Thank you. Grace, you get the last word.
Thank you. So first, thank you for having me on this esteemed panel. It's really a privilege as a non-bioethicist to be able to speak to these issues. As an ACIP member, I wanted to just reflect on sort of how we got here. To me, it's about the what and the how. And I think at ACIP, we try to focus on the what. And I have very much looked to the ethical principles that Kathy helped develop for the ACIP. And in terms of thinking about the allocation phases, I would say early on, I was really focused on understanding how to maximize benefit and minimize harm. And for me, that meant both thinking about populations who are at the highest risk of severe disease, but also at the highest risk of infection. And sometimes those overlap and sometimes they don't. So early on, you did see we had an emphasis specifically on frontline essential workers because we know that our, especially lower wage workers who really need to be in their job on the front line, interacting with individuals all the time, we were asking them to be at particularly higher risk so that we could put food on our table and so that we could function in our daily lives. And so I think that principle for me carried through in that particular form. Then the other component that has been so important and is actually very much nested into this question about maximizing benefits and minimizing harms is health, mitigating the health inequities we saw, or we continue to see, to be honest, in that we know that in order to maximize the benefit, we know that there are communities that are disproportionately affected by COVID-19 infection. And we see it like in our very nationally, at the state level, at the county level, and very locally, where you can go from one side of the street to the other, and you'll see very different rates of infection. So really thinking about how to incorporate mitigating health inequities into our implementation plan is important. And very much echoed from an implementation perspective, then it turns into the how. So at the ACIP level, we tended to focus on populations because that is sort of at a national level what we could do, hence the focus on long-term care facilities and then working our way down by age group across those phases, in addition to frontline essential workers, again, bearing a disproportionate share of the burden of infection in the US. That also, even amongst phase 1A, I will say that that plays out in every phase. So health equity is such an important issue amongst the healthcare workforce. So people tend to think about doctors and nurses. They're not thinking about the fact that we actually have many lower wage workers in our healthcare facilities who are supporting critical functions of our healthcare delivery system, and actually documented higher rates of infection than even those who are at the bedside caring for the patient. And whether or not the infection comes from caring for patients or from communities, I think the important point is our intention is to protect our workforce and protect our communities and make sure that we are getting vaccines to those who need it the most. So that's what I would say about the what. And then in terms of the how, I mean, this is where promoting justice becomes really important. As I mentioned, I think it is important at every stage and whatever phase you're in, and recognizing the variability across the states, that we can't lose sight of the what, which is ensuring that we build equity in addition to efficiency in every stage of how we deliver vaccines. But the how, and which is, how we do it might be different from state to state. How we try and address the health inequities may be different at the national level, at the state level, at the county level, at the local level. I've come to appreciate that as I've watched vaccines roll through, in that the social vulnerability index, for example, as one mechanism of trying to address health inequity by allowing states to allocate vaccines to communities that are hardest hit, I think is a really excellent approach, and one that is hopefully more practical, I think, for some states and counties to implement, as opposed to trying to understand who at an individual level every essential worker is. So that is one mechanism people have used to address health equity. And then, again, even at the hospital level or at the patient level, I think, we need to make extra effort to make sure we keep ourselves accountable to not only efficiency, but also equity. And those two, I think, should be visible and measured at every stage, so that we, again, make sure that if there are imbalances, either in access or in acceptability, that we are actually trying to address both of those simultaneously.
Thanks, Grace. So these equity concerns really highlight a tension that I think many of us who sit on these committees that are involved in making these allocation decisions find ourselves facing, which is the tension between this desire for being as fast and efficient as possible and to get vaccine in the arms just as quickly as we can, with at the same time being worried about issues around equity and who gets left out when you try and go as fast as possible. How do you think these demands should be balanced between trying to be equitable, which we've all been talking about here, and at the same time trying to make things happen as quickly and efficiently as possible? And let's go in reverse order this time. So Grace, I'll let you go first.
Thanks. I'll try and be briefer. So I think it's about intentionality. I think we can do it. We have to build our systems to focus on equity as one of the outcomes as we're doing implementation. What I would say is, early on, I think people were so focused on trying to get everything perfect and right that we were kind of not going as quickly as we should have, in part because we were taking a more, perhaps more of a punitive approach, in that early on, in December, people were saying, well, if you don't give it up fast, we're not going to give you more vaccine. So you were actually rewarded for efficiency. And if you were addressing equity and you happened to be a little bit slower, actually you were being penalized for it. So I do think that making sure that both of those metrics are front and center will help us balance out the fact that being efficient is not the only goal, that equity should also be the goal. And if you don't address both, then again, we're not keeping ourselves accountable for how we deliver these vaccines.
Okay, Monica.
Thank you. I think one of the things that we have to reckon with is that we're going to have an unequal distribution of resources that targets the populations that have been most affected, in order to most efficiently get a handle on the populations that are suffering the most, so we can most efficiently address the needs of the pandemic. But by so doing, that means that the hardest hit zip codes, and the people who are living in those are going to be at the front of the line. That is something that is politically untenable for many local districts. And so I'm seeing that playing out across the country. So in theory, that sounds like a great idea, right? But in practice, cities are saying, for example, in Dallas, like if you do this by zip code, by poor zip codes, we're not going to give you your vaccine. And so when the rubber hits the road, wealthier, more affluent areas are saying, no, 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 we want our vaccine first, or we want our vaccine at the same volume, even though our neighborhoods are not being equally affected. And so the issue is that we can still do the same speed, but we have to disproportionately funnel resources into the neighborhoods that are most affected. So if we take, for example, Chicago, we have maps of hotspots of where the disease is most ravishing our neighborhoods. Those are the areas that should be having a higher supply of vaccines. But if we're equally spreading out vaccine distribution, then that means that there's some neighborhoods that are under-resourced. And so we're not getting at equity fast enough. And so there are huge lines, there are people that are waiting that really need it, where some communities don't have as much need, but they're getting the same number of vaccines that are being allocated. But they have more social and political capital to press their aldermen and say, we need our vaccine. And so that's the sort of issue that Govind and I were talking about as far as equal concern. And so we have to, make these ethical principles not just principles. We have to make them into reality and stand by them. We have to make the implementation machinery work with equity in mind in real practice. And so we have to say, okay, as we look at the map of all of the pharmacies and we realize there are fewer pharmacies in poor neighborhoods, those that exist are going to have to get more vaccines. We're going to, as we're popping up vaccine distribution, points of distribution and sites, more of those are going to have to go into harder hit zip codes. So, we're going to have to think about this has happened, if we're going to have a system of a sign up of first come, first serve, which is the worst, idea possible. But if we're going to do that, we can't have the phone lines and the website go live on the same time, but no one's there to answer the phone until Monday morning. And the website actually starts on Friday evening. And so by Monday morning, all the slots are taken. And we know that, in certain counties, 73% of African Americans don't have access to the internet. And so then we what looks to be race neutral policies have devastating effects on, the lives of Black and brown people. We have to actively counterweight what appears to be race neutral or equity blind policies with equity in order to have what will ultimately be equitable outcomes. And so we have to put into the equation on the front end things like SVI, things like hardest hit zip codes, operationally thinking on the ground about ways that before we hit go, the machinery is going to make sure that we have equity in the output. Otherwise, we're going to continue to have disparities in what we see happen, and then wring our hands and feel like, oh, where are we? These are preventable situations. This is how we always end up with health disparities, but we're seeing them unfold right now, and these are entirely preventable.
Thanks, Monica. Kathy?
So I love the specificity with which Monica talks about particular ideas. I do want to say I was extremely pleased in the ACIP vaccine COVID-19 workgroup and ACIP overall that it was very clear that this collective group wanted to take seriously equity issues in addition to broader ethical issues. So, I think it's really clear that, we must not ignore the impact on individuals or communities who are disproportionately at a high risk of COVID-19 for a variety of reasons: lack of access to healthcare that's pre-existing, lack of access, inability to work remotely, the reality that a lot of people are working jobs that are public facing and they can't be physically distant when they're working from maybe colleagues or from the public, living in high density housing, so many different aspects. And one of the things that I think I've kind of grieved about as an ethicist is with the rapidness of the evolution of the COVID-19 virus and just changing knowledge and changing responses throughout. There's been really very little time to really adequately devote resources to community engagement over the last year. And I think that's something that we need to be very intentional about. So, just because it's difficult to look for ways to engage the community or difficult to try to tailor messaging that acknowledges vaccine reluctance or to create processes that make it vaccine really truly available and accessible in particular communities. I don't think that lessens our obligation that we must do that. And of course, we're doing this in real time as we continue to develop flexible systems for getting the vaccine out. But I think we want to maximize the ability that the vaccine will be equitably available within the phases as we move forward.
Great. Thanks, Kathy. Govind.
Yeah. So Dr. Peek said a lot of what I think I would want to say about equity much more eloquently than I will. I'll just make a few quick points. One is that I think when we think about why does speed matter, speed doesn't matter in itself. Speed matters because it's one variable that helps to contribute to benefiting people harm reduction. But if you get vaccines very fast to people who are at very low risk of complications, very low risk of transmitting disease, people like me who are professors working from home, that may be speedy, but it's not actually, it's efficiency at what, right? It's not efficiency at preventing infections, hospitalizations, deaths. So I think that largely speed and equity are really going to align, or at least equity and efficiency, pardon me, equity and preventing harm, actual harm, is really going to end up aligning, because it's when you reach those, socially vulnerable communities with crowded housing that you actually address complications, address spread, address these issues. No, I think there are ways that speed and equity can come into conflict, but it really is more where states have gone down the path of getting very overzealous about what I would say verification, saying, you have to fill out this 47-page form to show that you have, you're this age or you have this job. That can slow things down. I think that there are ways that equity isn't going to slow things down, maybe even will speed things up, would be to think about eligibility and proactive outreach as opposed to verification. So an area that I think I've disagreed with the ACIP about, and I know Monica has talked about as well, is that in defining the eligibility criteria by using 75 as the cutoff instead of 65, and there's been reporting on this more recently, that sort of disproportionately excluded some minority groups who tend to die earlier and suffer earlier COVID outcomes, Native American, Black American groups. And the other with proactive outreach is, again, instead of doing first come, first served, what you need to do, and would be just as fast, probably faster, but needs resource investment, is proactively call people, proactively do outreach. Don't just have a passive website sitting there, but have it so that you have, even if you have your passive website, maybe sign-ups start on Tuesday for Palo Alto, but on Monday for East Palo Alto. But better is that you go out, you make phone calls, you reach out proactively in communities. And Monica and I and a colleague of ours, Bill Parker, have a piece in Health Affairs talking about this need for proactive outreach to align speed with equity and with getting better outcomes.
Thanks. Go ahead, Grace.
Sorry, yeah, I wanted to just comment on a couple of specific things. So one is, Monica spoke about this imbalance in investment. So we know that there was $10 billion invested by the US government in vaccine development. And in contrast, by the end of December, there was only a few $100 million invested in vaccine delivery. So it doesn't do any good to develop these wonderful vaccines if we can't actually get them into the arms of individuals. That imbalance has been since corrected or is self-correcting at this point. But to speak to the points about preparation and intentionality, I think that we needed that time and that funding and that effort to be able to make sure we could build in robust programs to address both equity and efficiency. The second is that, I want to acknowledge the point about older adults. And I think that's why we had always tried to say older adults and frontline essential workers, highest risk of severe disease, highest risk of infection, and try to balance that throughout. I think what happened in reality was that the challenges with implementation became so significant, and there was much state variability that what we saw is that people dropped down the age without actually addressing the frontline essential workers, which have always been a critical component of the recommendations. And I do feel like we need to reemphasize and refocus our efforts on making sure that, and that was our attempt, perhaps a crude attempt to try and address equity as one of the key principles that should be flowing all the way through. But the implementation challenges made that become very imbalanced. And I do worry that actually the more we focus on age, that actually bakes in more inequity, which is not at all the intention. And I think that is what we were trying to address and trying to make sure that we built in. But again, agree 100% that addressing infection in communities who are at the highest risk of infection, that makes sense for all of us, because we really need to be able to not only protect those against those who are at risk for severe disease, but if we're not protecting those who are actually at risk of infection and transmitting infection, we are going to have ongoing community spread, particularly with the variants. And so this will not end. So it is actually in the best interest of all of us. It's not just because of the principle of equity, but because it's the right thing for us to do in order to address the pandemic.
Thanks. I do have some other questions, and if we have time, I'll come back to those. But we have so many questions from the audience. I think I want to move forward to some of those. So first, one question that's straightforward was somebody wanting to get resources that are mentioned by all the panelists. So if you go to bioethics.net, which is a website associated with our journal, you can see at the top we have a toolkit with resources around COVID-19. I believe all the resources that we're mentioning so far in the articles should all be in the toolkit. If they aren't right now, they certainly will make sure that they're up in the next couple of days. So you should be able to get all those resources that way. So first question. So Holly Tabor says that she wants to hear the speakers talk about how it can work to achieve equity across other dimensions, such as disability, which will not be fully resolved by approaches such as zip code or census track census housing, and to see how you think about addressing some of those kinds of concerns and issues. I'll throw it up, whoever wants to go first.
Oh, I see my name somewhere. So I think that disability would be one of the most physical disability, let's say, is one of the most extreme cases, but there are many communities who have barriers in accessing the vaccine that we still need to address. And so there are many health systems and health departments that are beginning to undertake mobile teams that are going out to communities so that the extreme elderly, those who are homebound for whatever reason, and other people have more access to the vaccines within their communities, within their homes, and don't have to go to mass vaccination sites where they may feel like they're going to get COVID while they're waiting in line, or can't even physically get there, or don't have the transportation or other things. So we have to again think about how we can, particularly for communities that have historically been marginalized, historically have not been reached out to, how we can show up for those communities, how we can reach out to those communities in a way that puts our best and brightest mechanisms, our best and brightest people who are going to show up with love and open arms virtually, and be willing to, engage in a respectful and trustful way in vaccine education and implementation campaigns. That includes people who are disabled, and making sure that we can reach every person that needs to be vaccinated.
I have a little follow-up on this related to the piece Monica and I and Will wrote on health affairs. One suggestion we make there, which I think is not going to perfectly reach, especially folks who have disabilities that are not in medical records, although things like zip code approaches can help with that. The suggestion we make is that if you have health systems that have large-scale health record access, instead of passive first come, first serve, reach out proactively to people who are facing overlapping risks. So within your eligibility pool, if you know you have patients that have these health conditions that are either conditions that generate eligibility or conditions that add risk within a category like 65 plus, reach out to those people by phone or by other means proactively first to give them access is another suggestion we make. I think a lot of states have been, to my mind, way too quick to say, oh, we can't use these because they're so hard to verify. People will show up and pretend. And I think if you work a little bit harder and leverage the resources you have, you can go a long way, not perfectly, to trying to do more than just say, well, we have to do it all based on age.
Great.
I'll just add one other aspect, which is, and this is more of a numbers thing. So I think I do hear that common challenge around implementation. And I will say at Stanford, I know David knows that we're doing our best to try and really address, how do we identify those who are at high risk, whether it's due to disability, chronic medical conditions, by communities of residents. But regardless, I think the challenge we have is that we need denominators in order to measure whether we're equitably distributing. And so, that denominator challenge is always going to be there. But I feel like, if we don't address it now, when are we ever going to address it? So to me, this is a perfect opportunity for us to not be perfect, to do our best, but to actually try and measure this. And this is where I think the measurement comes in, because we will always make our best effort, I hope, to reach out to specific communities, but we're never going to be comprehensive or systematic unless we're actually trying to capture this in a systematic way. So I would push all of us, health systems, counties, states, for us at the national level to make sure we are thinking about how to measure equity, no matter how imperfect, because we won't know how we're doing unless we're actually measuring.
Yes.
And I'll just add quickly, I think this is another perfect place for community engagement. I mean, particular communities, and also talking to professional associations that are working to advocate for individuals who are living with disabilities. So there are opportunities. We need to learn, right? We don't know how to do this well. We haven't done this well. And so actually pulling them in very intentionally, I think is important. I think we also need to be attentive to the reality that for some individuals with disability, how much do they want to disclose their underlying conditions that lead them to have impairments or disabilities? And how are we going, as we data collect, for example, how are we going to be protective and responsive to their concerns?
That's great. One of the questioners comments that one of the challenges of wrenching in mechanisms for health equity may unintentionally contribute to pitting disadvantaged groups against one another. Given that we live in a society with fully formed and functioning caste system, impacted this person's way of thinking about it, which raises the question of whether or not bioethicists and community partners, have we been effective enough at communicating the justification for our principles and algorithms in the public sphere. So when we're focusing on equity, several of you have commented on how it really is better, faster, more efficient to really have better outcomes and reduce harm more by an equity lens, so that it actually is better. But we're also at the same time seeing all this pressure coming from groups who really don't have to have access right away or have lower rates to get it as quickly as possible into those people. So would doing a better job of articulating the rationale, the justifications, the data, all of these things about why the equity lens is so important, is that something that we really need to do a much better job of in the public sphere to try and increase the acceptability of those efforts?
Yeah, so I think that too often, sorry, would you like to go ahead?
No, go ahead.
I think too often And sort of with an assist, I think, from people's liking to frame things around conflict. There's that New York Times article about elderly versus essential workers, and there's been a sort of push to frame equity and benefit as being in conflict, when I think, as all of us has tried to explain, really it's often not, because as it happens, the people who are most vulnerable are often the ones where you get the biggest bang for the buck in reaching them. What I would like to see more emphasis on is A, in sort of framing, talking about the alignment, but also B, in thinking about being intentional about focusing on groups that are facing overlapping risks. So risk of complications and also risk of infection. I feel like one reason why the essential workers got pushed down is that people came up with these possible hypotheticals of, well, what about if you have a 20-year-old healthy frontline worker as against people who are older? But I think the real area that I think could be emphasized much more is, if you're looking at people who are older in crowded housing, people who are medically vulnerable and still working, these overlaps are ways to really highlight the fact that equity and efficiency align. And I think more could be done in emphasizing that and incorporating it into policy.
Great. Monica, you had something to say about this, I think?
Yes, I think that it's important to, for both people of color and for white people to understand the way of understanding this around race, that it's not race, but it's racism that puts persons of color at increased risk for COVID. And so that we really are thinking about the structural mechanisms that we want to prioritize. So what we're trying to do is prioritize those who have increased exposure. And so that's individual risk and place-based risk. And so people who live in communities where there's, poor ventilation, people who have jobs that put them at, front-facing jobs with the public. All of these are things that are more likely to happen if you have brown or black skin because of structural racism. And so the higher rates of COVID mortality, COVID morbidity are related to underlying mechanisms of structural racism, and not just because you have more melanin in your skin. And so what we're trying to do is prioritize those people who are at increased risk for infection and increased risk of death. Not saying that, Black people have magic powder on them that we should, put them to the front of the line. And so it's not about that. And so that also, I think, for people who are Black and brown and are somehow hesitant that they're going to be getting some special potion from the government, and may say, whatever that is, I'm not sure I may want that. That's not what we're talking about either. We're talking about the reasons that you may be at increased risk. And those reasons may be shared with people who don't look like you. It may be, people working in a meat packing plant in the South who have white skin. It's all of the people who have this increased risk that we're talking about. And so some of those people are going to be disproportionately persons of color, but not all of them. And so that allows, I think, for a bigger conversation about equity that takes race a bit out of the question. And I think allows us to think about equity and fairness in our society in a way that may be more palatable for people, for everybody, at least hopefully.
Okay, next question. If uptake is inadequate to achieve herd immunity, is there a role for making vaccination mandatory for certain groups, for example, based on their profession, like healthcare providers, or risk to others, like caregivers of vulnerable groups? And if so, how do you balance the competing ethical principles for mandatory vaccination? I'll start with Kathy.
I think we're in a period of time right now with everything evolving so rapidly and so much uncertainty, both about treatments and about vaccination and virus, that it's preliminary to think about mandating vaccination at this point. So I think there will come a point where that question will be, I'm sure, in front of healthcare systems, just as we went through this with the mandatory flu vaccines and several years of a decision process and doing focus groups, et cetera, to determine whether this was ready to move forward. I think we're just preliminary for that kind of a conversation, even for healthcare workers. So I also have to say that I would have a great concern about the potential for increasing mistrust by moving toward mandating vaccination at this point. I think there's a lot of questions in people's mind that are quite important. They're important values for them. We need to explore them. We need to acknowledge them. And we need to be responsive to them. And then we need to gather more scientific information about the effectiveness of the vaccines and the course of the virus moving forward. So not yet.
Any other thoughts from any of the other group?
My colleague Emily Largent and I have a piece that in JAMA Network Open that looks at public perceptions on this. And I agree with Dr. Kinlaw that it makes sense to not do mandates broadly right now. I think it's right to say it's premature. There are a couple areas where I do worry about not having them at some point down the line where I think they may make sense, which is where you have people who are entrusted with looking out for others who cannot take the vaccine. And that would be maybe people with medical limitations who can't take a vaccine, or if kids are not authorized to take one. Those would be areas where if you're in charge of protecting people who are not able to be vaccinated, those are areas where I think a mandate could potentially make more sense, because it seems ethically different to put others at risk who don't have the option of protecting themselves.
Any other thoughts from Monica or Grace about this issue of mandates?
Yeah, I mean, most hospitals have a mandate for a flu vaccine, with the exception that you can have your provider say, an excused reason why you don't get it. And so I think ultimately we will get there, but I think that the negative backlash and impact from that would outweigh the benefit of not having a mandate right now.
I agree with the other three panelists. We're not at that point in the vaccination program. First of all, we're under EUA for all our vaccines until we get to a different point in the pandemic and we have more experience on effectiveness, safety, and specifically, we're waiting to see how things go with the variants. We remain cautiously optimistic for the vaccines that we currently have available, but we will have to monitor and we'll know more soon. And until we have vaccines that can protect all the children, and I think there's a lot of individuals where they may not be able to get vaccinated, as was mentioned. My question is, are we really going to be able to achieve herd immunity? I think that we do have a moral obligation to get vaccinated if we are caring for fragile individuals. That's my personal opinion, but I think that's different than a broad mandate at this point.
So related to this, some people talked about whether or not there are ways of nudging people to do this short of mandates, but also somebody points out that one of the nudges in the opposite direction is the fact that this isn't FDA approved, but it's instead under an emergency use authorization. So I guess one person asks, when do you think it will be fully FDA approved as opposed to under EUA, which might help promote it, at least some populations, or at least some people in the chat, in the question and answer session, are reporting as a basis for some level of vaccine hesitancy. And how should the FDA ethically be thinking through that process, knowing that the EUA may, rather than full FDA approval, may be partly grounds for some level of vaccine hesitancy?
Well, I anticipate that the vaccines that are currently approved under the EUA are moving towards biologics licensing applications. So I do anticipate that will come to pass. And I think the earliest might be early summer, late spring. But we are I'm cautiously optimistic, in part because I am hopeful that some of the data on at least kids down to the age of 12 will also come through, which I think would be, for us who are in pediatrics, be really helpful for all of our vulnerable patients.
Any other thoughts from the rest of you about this issue about FDA approval? Nope. Okay, moving on. So there's some questions about the international aspects of the vaccine. Some folks are worried or concerned about the fact that people in other countries also face the pandemic as well. And so how should we think about allocation of vaccine, not just within the US, but internationally, and whether or not it's reasonable to ask people in developed countries to potentially forego the same amount of vaccination in those countries so that we can do a better job with people in other countries?
So I'm happy to take the first shot at this because it's an issue that I've written about with a large group of other folks in bioethics in science in a piece called A Fair Priority Model for Global Vaccine Allocation. What we argue there is that we think it is reasonable, although there's disagreement among us, for countries to prioritize their own residents for access to COVID-19 vaccines, but that the reasonableness of that sort of priority for your own, it's only reasonable up to a point. And there's a point, we're not at that point yet, where once you get the sort of burden of the pandemic down substantially to where it, say, really does look more like seasonal flu, that it then becomes more of a moral imperative to get the vaccine to places that aren't getting any of it right now. That still leaves, I think, two major ethical questions open. One is, I think people argue, and I think with reason, they say, look, that's too slow. If people haven't gotten any vaccine at all in some countries, there should have to be some going even now, even while there is still a pandemic raging in the US. As a kind of practical matter, that's less of an issue because the vaccine that we're using here is not as well suited for a lot of international settings because of the cold chain requirements. The AstraZeneca, I think, is the one that COVAX, the WHO, is focusing on more. So sort of by happenstance, there ends up being less of a direct trade-off there. The other ethical question, which sort of conversation with Monica brought out for me, is that even if we get to that point in the US as a whole, what to do if there are still communities within the US that have not received the same degree of vaccination as the US as a whole? What does it look like then to start looking more at sharing globally? I think not enough has been done to ramp up supply and to build that supply chain for getting vaccines out to other countries. I do think to the extent there really is a trade-off, which I think at least right now less so with the Moderna and Pfizer vaccines, there are really challenging, complex ethical issues there.
Okay, great. Other thoughts?
I think this is a really powerful question. And I think it's really time for us to be more aware of the global nature of all of the efforts occurring. And because of the rapidity of course, spread of the virus, working together with a commitment to the well-being of everyone, really, I think best benefits each country as well. So stopping the spread of the virus, keeping individuals from having severe illness, also addresses the global economy that is so intertwined. I think we're maybe acutely aware in ways that we haven't been before about how much we all have in common, or that we're suddenly realizing that in a different sort of way. So again, it may take some time for us to make an actual commitment of a percentage of vaccines from the US to perhaps be shared with developing nations, but I think we need to seriously be about that conversation.
One thing that I would add is that we may be looking at this in the wrong way. So rather than saying that the cost of the vaccine is so expensive that it's one that only developing countries can afford to purchase, and then we need to be able to share it with the countries, who can't afford to get it right now. There are other calls to say, release the patent so that the vaccines can be cheaper, so that the lower income countries can then afford it on their own, which I think may be a more viable strategy rather than, because what I'm concerned about here is that we've already seen, or what are they calling it, vaccine tourism, where people are going to places pretending that they're people who they're not to get vaccines. And that sort of stampede will just get accelerated if they know that Americans are not patient people. And so if we say, you know what, we're going to prioritize the disadvantaged here, and then we're going to prioritize the disadvantaged in Bangladesh, then we'll get to the low risk people here in America. That's not going to happen. Let's be real. And so it's just, that's not who we are as a country. And so I think that if we really want to think about how we can be better global partners, rather than trying to twist ourselves into being who we know we are not, we might want to think about other ways that we can advocate for getting vaccine access to low and middle income countries.
Great.
I really like that, Monica. I think that's a great way to think about it. I hadn't thought about it that way before. I do feel like we, build all these beautiful ethical frameworks and these principles, and then as soon as implementation hits the door, it feels like it goes out the window. So I do worry that even if we develop these commitments, which I do think we need to do, I will say, I think COVAX is an outstanding initiative. I do feel like, we need to be at the table to support that overall global initiative, because again, until we can help everybody, no one is safe. So I do feel like that is critical, but 100% agree that this pandemic has brought out the best and the worst in everybody. And I worry that that instinct and that fear actually ends up driving behavior more than our ethical principles. So I appreciate the very pragmatic approach.
Okay, one person raises, have a couple of questions about some very specific challenges and problems and things that might help make a difference. So one person points out that even when vaccine clinics are being set up in very hard hit areas with people of lower socioeconomic status, disproportionately people who have higher socioeconomic status are showing up for appointments in those areas and are coming to those areas. Maybe they've got better computer access, whatever the cause. It means that well-meaning efforts to try and ameliorate some of these disparities and inequities are wind up being overridden by people seeking out vaccine in those areas. How practically and a politically acceptable way can these problems be corrected?
My initial thought about that is, you're trying, which is good, by putting your site in a certain area, but that effort is still not proactive enough. It's still passive. You're still having your site sitting there and you're waiting for people to come. If you reach out proactively to, say, people in your EHR that have high-risk conditions, if you bring vaccines to people, to some extent, maybe you don't get rid of that problem entirely, but you obviate it. I think it's not going to be a bad thing to make vaccination sites accessible, but it may not be enough, from the example talked about, to fully address the disparities and fully achieve either equity or maximizing benefit.
I would just add that in addition to what Govind just said, that the idea of decentralizing vaccine administration sites and actually having places where you can go to get the vaccine that are in your community, but also in places that are already known and trusted in the community. So if there are sites where people already have relationships, that to me seems optimal. And for those organizations then to be communicating directly with people who are already in their community of trust to come and get the vaccine. So I think that kind of a outreach, but also building on trust relationships is important.
Great. Another suggestion, an interesting one, is whether or not it makes sense to give individuals the right to exchange their vaccine to others. So people who are in a higher priority group and hence are entitled to get a vaccine at a certain point in time, but realize that they have the luxury of being able to work at home. Should they be able to essentially trade so that and give their slots to other people so that lower priority groups could move up in line for other kinds of reasons, or should all such trades be prohibited as they are now?
On one level, I'll say, the idea that foregoing one absolutely leads to the allocation to someone else who's more in need or more vulnerable or high risk is, I think, a questionable equation. I am not sure that that is a reasonable pathway unless we have very different processes in place for identifying who those people would be. Govind, I saw you shake your head vigorously. I'm curious what your thoughts are.
Yeah, so I think this idea sort of nicely encapsulates, I voted up this answer because I wanted to answer it, encapsulates a mistake that I think is run through our COVID-19 response that I see even now, which is that I think that we keep thinking about COVID-19 vaccines as a medical intervention, as a sort of thing that you give to individual people to benefit people, as the equivalent of something like ventilators. And I really think that we need to think about them as a public health intervention, and to think about the fact that when you vaccinate somebody, it looks very likely that there's a reduction in transmission. So there's an indirect benefit in that way. And we also care about other indirect effects. For instance, having health workers that can help people in need, things like caregiving. So I think the flaw to me in saying that you should be able to trade a vaccine to somebody else, while there's an initial appeal to it, that focuses on the idea that the reason why we would give you the vaccine is to help you. That can be part of the reason, but a big reason why we might give somebody a vaccine is to help their community, or to help their patients, or to drive down spread in an area where variants are high. And letting me, if I'm fall into that category, I'm not going to for a variety of reasons probably, but if I did, saying that I could trade the vaccine to my mom in Texas, like I would love to do that. But if I were getting a vaccine, I might be getting it for a reason that isn't about helping me. It's about stopping spread, or it's because I'm a doctor, or it's for some other reason. So I guess that's why I would be hesitant about the trading idea. The one caveat I would have is I do think we might want to think about a mechanism for allowing some portion of the vaccines to be eligible through a lottery to the general population to get around some of the pressure that I think, as Monica mentioned, otherwise people are going to push on every other avenue to get to it if they're not in a prioritized group. Throwing 5% of your vaccines in a general lottery might actually be ethically advantageous in that way.
Interesting. One person asked whether or not there are any communities in the US or countries outside the US that you think have done a relatively good job of equitable vaccine allocation. For example, Israel is often mentioned as having done particularly well at vaccine rollout in general. And do you think if there are places that have done it, what are the lessons that can be learned from those places?
I'll just chime in that I think, national leadership and coordination, it certainly helps. The way that we've done it in a very distributed and local fashion, in some ways you have to distribute vaccine locally because you need to understand the local context to make sure that you provide sufficient access and, ensuring that you're getting the right education to the right people at the right time. On the other hand, I think I have bemoaned the fact that we had lacked that early on, that sort of national coordination, speaking with a single voice, that I think was just so critical to get us through these early weeks of vaccination. And I feel like the dissonant voices created confusion, and I think a little bit more panic than was necessary by the public, because there wasn't a single sort of strategy that was laid out. Again, recognizing that implementation is very local and needs to be adapted, but at least the strategy itself, I feel like, could have been supported by that. So I do think Israel actually is a great example of, there was a clear strategy, there were stages of implementation, everybody sort of knew what they were and knew what to expect. And so it seemed like a more straightforward rollout to me.
Yeah, to me, people talk a lot about Israel as an example. I think it's interesting, but also revealing in ways that I don't think that would replicate here. You have a very small country, you have a population of the people they vaccinated, which wasn't, say, the Palestinians on the West Bank, that's much more homogeneous, where I would worry a lot less about using an age-based approach in a very homogeneous population. To do that here, just using age as the only criterion, would seem to me likely to be much more inefficient and much more inequitable. So I'm really, and I've said this a lot, I just think age is an important factor, but saying that you want to replicate that allocation model here, I think wouldn't be equitable or efficient. For here, actually, I would look at Alaska, which is a sort of funny example. They have really high rates of getting people vaccinated. And part of why is they were very proactive in like sending vaccine out in like planes to remote communities. They also got more vaccine. And part of why they got more vaccine is that there are a lot of Native Alaskan folks and Native Americans have been a very vulnerable community, probably by sort of numbers, the hardest hit per capita for COVID. So by going away from that population-based approach and going to more a kind of risk-based approach, I think Alaska, I would say being proactive and allocating based on risk, just not just on population, are two things that I would look at.
Any other examples that anybody else can think of that particularly useful as and instructive for doing it well? We wish. So that's that says a lot. So we've got Alaska to look forward to. Another question person in the audience asks about your thoughts about an appeals process. Should there be some kind of an appeal process built into the allocation system so that people could sort of essentially get their way up the queue on the basis of some kind of an appeal?
No.
It's something that is used in, I'll just say, in organ transplant allocation. There are pretty clear criteria, but there are appeal processes where you think for there's an exception to whatever rule that gets made. So this is why this person should be bumped up higher. So do you think that should be done here or not?
Yeah.
I don't think so. I guess, Monty, I feel like I'm talking too much.
I mean, everyone ultimately is going to get the vaccine. It in a relatively short period of time. I think this and organ transplantation are radically different. People who are waiting for an organ transplant are essentially, hanging by a thread on death's door any minute, if they don't get that organ. This is not the case. We're essentially trying to vaccinate the healthy population to prevent, an illness. And the potential for the bureaucratic administration of people trying to say that I'm a low risk person, but I should get mine higher is just going to clog up the system. And make everything slower and make us less efficient. And we have not been like winning any gold stars for efficiency already. And so I think that we need to just like focus on getting down to the business of targeting the high risk folks and getting them vaccinated and making our way through the line.
To that, I would just say, I think this again underscores the mistake of seeing it as an individual medical intervention like transplants. This is a public health intervention. And the other thing we know about appeals processes, like maybe I should like them more because of having worked on a court of appeals. They're a disaster for equity in this respect. The people who are going to use the appeals process are going to be the more advantaged people. And you've seen this in sort of other settings where this has happened. It's going to end up leading to either the kind of equivalent of defensive medicine where people stop wanting to use sensible criteria because they're worried about appeals, or as Monica said, it's going to gum up the process and the people who are going to be using the appeals are going to be people who are advantaged. So no, I don't think this is the right setting for that kind of
I agree wholeheartedly. I think the diversion of resources away from other much more important aspects of the COVID-19 virus work would be disastrous, and we would not have criteria for how those decisions would be made. And so the lack of fairness or consistency in decision making, all of those things, in addition to the fact that it doesn't meet the same critical care resource kind of distribution questions. So I think not.
Yeah, I'll just say I agree both on the trading question and the appeals question. I think neither makes sense from an implementation perspective. I don't think it will help, basically. And it will make things more confusing and potentially slow things down and perhaps make things less fair in the end.
So I think we're almost out of time. So I want to ask one last question from the group, which has to do with some of the supply chain aspects and logistics of vaccination and the ways in which those wind up contributing to racial disparities in vaccination. How can we change the supply chain factors that to make a vaccine allocation more equitable? I know, Govind, you've been talking a lot about the idea of being much more and somebody else, one of the other questioners talked about passive versus active approaches to to allocation in their question, which Govind, you've been talking about. But I know the logistics, I know for our institution, talking about trying to make, for example, phone calls to all of the patients that we have in our system may not be logistically possible. Reaching out to people, it's easier if you do it through a portal, but or an app, but it can be challenging to reach. Then that can create other inequalities. So what are some concrete things that we can do to change the supply chain to make it more equitable and to address these logistical hurdles and barriers to equity?
I'll just pick on you a little, David, right? But I'm not always good about making my alumni donations, but Stanford Medicine may be in a different place, but Stanford has how many $1 billion? I got calls every day from people telling me to vote for this or that candidate. Surely more could be done to sort of recruit people who are not working right now to get them in a position to be able to call people to proactively outreach for vaccine. Now, calling might not be the only route, but I guess I would just push back against the idea that the resource limitations are so hard that it's important for Stanford to do it. Because if it's impossible for Stanford, then it's really bad, but I don't think it's actually impossible. I think Monica can talk more about what they've done in Chicago, but that's just my hesitancy about conceding too fast on that.
Yeah, so one of the things that we're doing is for people who have been offered the vaccine and have declined, we have a whole cadre of medical students who are then going with the script and contacting those patients. We also know that there isn't a digital divide for cell phone usage. And so we have everyone's phone number for pushing out emergencies, right? So we can push out text messages to all of our patients. And we've done that for other reasons. And we a lot of times will text out reminders about appointments that are coming up. And so while there may be issues around using an internet-based portal or other things, we can certainly use people's cell phones for messaging. So that's one small thing. People count. So I would say trusted people, spaces, and places. And there's a whole conversation. The other is that we have got to use the limited resources we have and push those into high need areas. I just can't say that enough. And so I'll just stop there.
Okay. These are all very good concrete suggestions. Any other last concrete suggestions for how to optimize reaching to those communities to address equity, especially in terms of logistics and supply chains?
I just echo the get to trusted organizations or congregations or whoever in communities as an important part of the collaboration. And just an interesting addition, we've actually had a couple of examples in Georgia where we've had private individuals who work in the space of messaging step forward and provide for free some apps and other resources that actually are based on text-based messaging. So it's interesting to even think about what are the models that might be out there that have begun, or tapping others in our communities to join this effort.
Thanks. Those are all really well-established and validated approaches that we know work in recruiting populations that are hard to recruit for research. So it makes a lot of sense to be tapping into those things. So I want to thank all of our panelists for a very stimulating and very interesting conversation. And thank you to all of you who have joined us today. Hope everybody stays safe. Thank you very much.